Are we live? We are live. All right, fantastic. All right, everybody, it's just awesome that you guys have supported us while we started live streaming and bringing in healthcare experts and various thought leaders. And we're actually really excited about this conversation. One thing that you hear us talking about a lot is AI, next best actions, data science. But how can all that happen if we had the absolute best data scientists in the world, but no data for them to run models on and extract and look for relationships? Then having all that talent there is kind of a moot point. And that might sound ridiculous, like, okay, a data scientist with no data, but it is far too often the fact. It is heavily a reason why a lot of data science initiatives in healthcare or data science departments, healthcare and tons of other industries, how some of these initiatives can fall apart and organizations don't see value from their data science efforts. So it's important not only to have people that are capable of the modeling, identifying next best actions, using AI to find relationships between patients, actions, encounters, biomarkers, et cetera. But now that there's a huge focus on how do we get all of this data there. And in healthcare, we know it's been a big problem with all the silos that exist between systems, between vendors, between business practices, between organizations. All of that is on the way to breaking down with new regulations, new discussions that have been going on at the national level with CMS and with a lot of conversations that are happening now. And we bring you to the central point, and is leading those efforts heavily within MultiCare. So we've heard at the high level on what's coming on from CMS, what we're hearing from CARIN and DaVinci and these other efforts, the Blue Button Initiative, to tie these systems together. And we brought Anne today because she's enabling these data science efforts, these next best actions to be detected across these systems with a lot of things that we're going to go deeper into in this conversation on interoperability and the role of data science in healthcare. I do want to point out that there is a little bit of an issue with the sound today. So sometimes live streams can't be perfect in terms of the audio, but please bear with us, because behind the clicks, behind the pops, there's an awesome opportunity to have a conversation with somebody who's doing some leading edge things in healthcare. So just keep in mind as you are listening, feel free to interrupt us with questions, comments, what have you, because we like to have this as an interactive session. It's not just us talking. It's not just Anne from MultiCare talking. It's the opportunity for you to kind of understand, well, like, this is hitting me at a certain angle, or I have this challenge in my organization. What have you seen similar how have you addressed similar challenges? So on today, wonderful co-host Vital Shah, who is our Chief Operating Officer at Symphony RM and has led digital transformation efforts at top 10 hospitals across the nation. And Anne Goldman, bringing an extensive background, not only on the technology side, but very early in her career. She went to Emory Health, studied for an MPH as well. So the public health perspective is there, mixed in with consulting and technology background. So it's a very well-rounded position that she's taken from that early starting point in Atlanta, Emory, Grady Health, to Providence. She's taken over the entire Pacific Northwest now now working at MultiCare. So Anne, any words for the audience before we go ahead and get started?
No, thanks for having me. Happy Friday.
All right.
Happy Friday.
Okay. Indeed. So yeah, thank you very much for joining us. And we just want to get straight into the questions, because I know that among the audience, we typically have a mixture of people on the technology side, but also on patient engagement, operations, and finance. So I just want to start by helping get everybody on the same page on what's going on with these interoperability initiatives. Are systems going to be expected to be able to talk to each other? Like Epic is going to have to talk to other vendors now. So let's get into just a high-level state of the union on the big interoperability standards being discussed today around CARIN, DaVinci, and I'll just let you take off on that.
Right. So it's a lot, right? And just what we need more acronyms, right? So right. So FHIR is just really HL7 over JSON, right? And the FHIR resources in the past few years have become more sophisticated and more developed so that we actually can use them. So just to break out, because MultiCare, the organization where I'm employed, we are part of CARIN Blue Button, but we're also part of DaVinci, and they are two separate things. So they are very much interrelated in many ways, and they both do have the backing of CMS and other parts of the federal government. So CARIN is more consumer focused, and that's CARIN with a C, CARIN. And that is more about you as a consumer having access to your healthcare information, whether it be a payer or a provider. DaVinci is more about the payer to provider, I should say, interchange. And that is, you might say, well, how does that really help patients or help the consumer? Well, it does, because it helps in both lowering cost once it's established and working for the organizations, but it also helps in becoming more efficient and timely. And we can get into the use cases. But the DaVinci project that we're working on with a local payer here in the Seattle market, it's gotten a lot of traction due to the recent interoperability guidance and regulations coming down from the government. So,
and do you think? I think I was trying to go back, looking at previous HIMSS, and I think interoperability really started gaining steam in 2004 when ONC was started. That's like 16 years ago. Do you think we're finally at a point where there's momentum going into some of these initiatives, and they're going to actually pay off for both patients and providers and all those sort of entities that are involved in the exchange of data?
Yes.
Awesome.
I actually think we have jumped the shark, so to speak. I do believe we are finally going to be able to take advantage of all this investment. But that doesn't mean that it'll just happen for you.
Right.
As an organization, there's still a significant amount of lift on the organization side, but there's a couple things that have played into this. I think there's been just early adopters have had success, just a normal kind of, I say, maturity curve of any technology. But also I believe that we have engaged leadership on it. But I think another factor here is the big technology players that help healthcare organizations are also investing in this quite heavily, and they're very, very much want to see it succeed. And so it kind of gives you a jump start as an organization to be able to invest in this rather than kind of building it yourself.
Yeah.
So that's why I think we're right to actually make this happen.
Yeah. I was going to say, Chris, I think I'd love to dig in a little bit with Anne on these specific initiatives, CARIN and DaVinci. But Chris, you mentioned earlier, without data scientists have it'd be a pretty tough job. Anne, I'm curious to know, what from a population health perspective, value-based care perspective, I'm assuming interoperability is one of the main focus points or levers, right? Because without it, you can't really aim at the triple aim or the quadruple aim, right?
You can't. Well, you can, and we're doing it now. Just it's struggle.
Can't scale. Yeah.
And I'll give an example. The lag time for at least on the DaVinci side, the lag time between providers and their payer to get information is at least 45 days, if not a year to a year plus.
That's right.
And so, and the kind of conversations and the type of data wrangling, if you will, that takes place in order to have those conversations, it's a lot of manual effort that is going to be resolved through interoperability and make it instantaneous rather than a year lag, which is in one of our payers going through back and forth over a membership file. We're now a year plus and trying to sort out the errors in the attribution.
And we got an interesting question, and it kind of ties into something that I wanted to bring up a little bit later, but we're talking about establishing these standards and the work that you're doing. That's ultimately we're seeing that there's more momentum behind this. So as organizations are beginning to take this on and adopt these efforts, I bet they'd be pretty curious about, hey, well, how do we know if we're doing well? So Mike Leonard, it says LinkedIn user, but it's Mike Leonard from our company. He asks, are there specific people, metrics, or results that you have in mind as far as success measurements?
Yes. So first he's asked, you mentioned earlier people having success. Well, this is where the government is way ahead of everyone else. So CMS has had great results with this and now is mandating it, well, highly suggesting it now, we'll mandate it later for everyone to follow suit. So that is our early adopter. In terms of what is a measure here, well, the instantaneous nature of being able to exchange information through FHIR, that is the success in itself, how we're able to respond to errors, whether it would, with any of these use cases, gaps in coverage, I'm going to name the 3 later on, but membership, or even our Med Recon, which we're currently in our auditing phase, the time saved in the error reconciliation alone is a very good metric for success.
Excellent. And so moving on from that subject, kind of wondering, like I think that our expertise is more so on the CARIN side of the house, but we're very curious about what you're doing with DaVinci as well, as far as the payer relationship.
Right. So we have, by the way, I wanted to just do a shout out. I do not do this alone. Okay. There is a team that I'm a part of that this would not be possible without them. So Melanie Matthews, our president of our population health company, MultiCare, Connected Care, Anna Taylor, who's her director of operations, as well as Brad Busick, our CTO. They make this possible. So I am indebted to them, and I am part of their team. So going back to the use cases. So we are in the med reconciliation post-discharge use case. That is our first use case that we are underway. We started with Regents, which is a major assure in the Seattle area. And what the med reconciliation post-discharge, so being able, once you leave the hospital, you're discharged from the hospital, the medicines that are prescribed to you and the medicines that you are taking when you have that follow-up visit with your primary care or your specialist in the office, that is a measure on a lot of value-based contracts. And there's a reason for this, right? Particularly with our seniors who, I got to tell you, I worked in pharma a long time, and I am confused on my orders with medication when I've left the hospital. So I can only imagine for our seniors how difficult this might be, as well as anybody else. So having that true up on the medications, making sure you're taking them correctly, there's not any contraindications and so forth, it's very important. And that's why it's a measure for value-based care. And getting this information from the payers to the provider on a timely basis within that 30 days it's just been really challenging. So, and it's been a manual process in the past. So that is the piece that we have focused on first. And it was one of the first use cases actually out of DaVinci. And so really quickly, just going through the steps, if you'd like me to, because I'm sure for some people this is brand new. First, you have, of course, the discharge, right? And then you have the discharge medication list, right? And then you need to exchange this medication list with the actual provider, who is, and when I mean the provider, not the provider who perhaps did your surgery or who wrote your medication prescriptions in the hospital, but your provider that you do the 30-day follow-up with.
Yep.
And then you need to also have these medications listed in the EMR for that 30-day follow-up. And then there has to be the reconciliation, and there has to be the attestation of that reconciliation. And that attestation is the part that we're auditing right now as part of DaVinci, because the attestation is not necessarily chargeable. So how do you drop that you've done the attestation in the provider office? That's why we are had to actually augment FHIR with some work in Clarity, which is the Epic relational database for those who might not know. So that is the use case that we are working on right now. And how did we enable it? We have an API gateway. We do not actually have we are standing up our FHIR server actually through Azure. They have been wonderful partners with us, and FHIR as a service is something that they offer. You can either manage it yourself or have them manage it. We're still going back and forth on that. So we are working not just to receive this data, but also push the data back to the payer as well to make sure that the attestation is done, not just with the Clarity file to say that we've attested, but also the information through FHIR. So
great.
So that kind of well, did you have a deeper question about DaVinci, Shital? There was something.
Yeah, I was going to ask from a payer perspective, and what are some of the benefits they gain? Obviously, med reconciliation is important from a patient perspective, from a quality perspective, and the payer obviously has some skin in the game as well. So what are some of the elements there from a payer perspective?
Right. Well, they want to make sure patients are taking the medications, right? That you need to take post-surgery or post a long-term stay in the hospital, as well as the errors around medications. This is something that's very important to the payers as well. So all around beneficial to have this information more timely.
Got it.
So where I was wondering, oh, I'm sorry. Did you go on mute? Shital, can you hear Anne?
I think Anne's on mute. I think
you were muted for a second.
Sorry. Go ahead.
Okay. I thought I was out. Okay. So we've we've talked about the high level, like at the strategic level, what the value of interoperability is. Then we went into to some technical aspects, and then related it to payers and providers. I'm curious, how do you think about the patient how does the patient experience factor into all this?
Well, they're meant to be the center of everything we do. And, I actually like this use case with the med recon, and we can talk about the others. But the patient technology should be invisible, right? So if we are doing this right with the instantaneous push of the medication list into the EMR, into the provider's context in that office, the patient is benefiting as long as it's invisible, right? So that's what I really like to think of. I'm like, how can I make this as seamless as possible so that that office visit is a good use of time post-surgery, because there will certainly be other things that you are grappling with as you are discharged from the hospital.
That makes sense. Shital, anything to add on just interoperability and where that helps put the patient in the center?
No, I think there's obviously a number of metrics that will measure success out of this, right? I guess, and readmissions. I'm really curious to know actually how patient experience scores do, right? Because if everyone is almost on the same page of many use cases, med reconciliation is just one example. The patient truly is at the center. So there should be some quality outcomes gains. There should be some gains from a patient experience perspective. Cost, obviously, in many ways, because you're preventing some costly mistakes and the like. I'm assuming that there's some joint metrics that both the payer and the provider are probably going to be looking at to see if it's a success. Is that right?
Right. So that's what our auditing process is right now, trying to determine. So first we had to make sure it worked, and then that the measure for value-based contract was actually achieved. And now is to see how do we ensure that this is a highly reliable methodology, right? That this can work every time. So that's what that's what part of our audit process that we're doing right now is looking to uncover. So.
Now, I was thinking about the people who are watching who might be at organizations that are, more or less forward on the technology scale and adopting some of these new approaches. Could you talk a little bit about what initially got MultiCare interested in being a leader on adhering to these standards, and kind of how that started, and even some of the road bumps that kind of came in the way while these initiatives were being pushed for?
Right. So firstly, our CEO lives and breathes population health, and he means it. And he is willing to invest and be a loss leader to make population health be the center of, or one of the 3 strategic pillars that we operate on. He is, and he is experimental and willing to, how should I say, check and adjust or redirect if things aren't working and still invest. So without that, this would not be possible. So I do need to thank Bill Robertson, our CEO. He's a phenomenal leader. Again, the team this is the hardest part of this, is to sell this to the organization, because this is not easy to understand right out of the gate. Even as a technologist at first, and I did some programming work in HL7, really to understand the complexity of how to set up the systems. It is not easy right out of the gate, and it does take an investment in money and time, and not doing this at the side of your desk. You have to make this a top work priority. So we also had to solicit a technology partner that wanted to take the lead with us. And so I personally leveraged some personal relationships to ensure that would happen. But I know that now the technology players such as Google, such as Microsoft, who we work with, they want to jump in with clients to do this. And so at the time, like 2 years ago, it was a little bit, when we started this work, it was a little bit more on the fringe, not so much anymore. It's very much how they're investing in healthcare. So those were 2 of the, while selling it to the organization and getting the funding, and how the story applies to the bigger picture of what we're trying to do in population health. We also had to solicit the partnerships, really, and also on the payer side as well, to work with us. So, and that's why the DaVinci project has been so great. It really kind of hands that up to you. So.
When looking at this, so it sounds like there was massive support from the CEO, which is awesome. I'm wondering if there was, like, for people who are going to have to navigate within their organizations, what kind of resistance did you encounter, or what were some of the pushback that you guys have encountered in getting this set up?
Well, I think the pushback is we have a process now that works, even though for all intents and purposes, it might as well be broken because of the time lag. I mean, so I had to really sell it in terms of dollars, right? If you're so used to doing things and you just accept that time lag, that 45-day window to receive information from the payer, and what that means to a patient in terms of finding an actual per day, per dollar ROI, if we actually invested in the technology, that's really got us over the hump. And we also had a kind of interesting project that kind of came our way, where we could actually illustrate this with our partnership with Primera and P-Care, where we were actually able to play out how an investment in this sorts of technology and in a dollar-wise asking for capital could help us. So I think that's advice I would give anybody who's on this journey, is to really find your pain points and put a ROI benefit on them. And I certainly am available. You can reach out to me, my contact information, to help on that, because I think that was the last time. And some of the, I wouldn't call them resistors, I would just say happy with status quo, not happy with status quo, but comfortable with status quo, didn't really fully realize how much, they were only seeing their work, they weren't fully realizing how that log was affecting their coworkers until it was sort of illustrated for them. So.
And it looks like you're going to be hit up for a bunch of business case conversations. We might have to make it a webinar on ROI to interoperability.
Yeah, I imagine that one. It's hard. It's hard to sell technology to the organization at times, so I understand.
Well, I do want to put a plug out there. If anyone hasn't seen it, I had the opportunity to see it yesterday. And you presented a session with NACOS on the future of population health management, data sharing being the change agent. I thought that was a very powerful topic where the change agent actually is the exchange of data. We'll post a link in this in our LinkedIn live session, but there's a great video out there, and I guess you presented with Melanie and a few others as well.
Anna Taylor, yes.
Perfect.
There were a lot of Anns on the panel, so you get to listen to a couple Anns before me, I guess. So.
Yeah. So on the change agent piece, I'm curious to know, like, you mentioned that there was a bit of resistance because there was a process in place that was costly from a time perspective. You built a business case, and then you had executive leadership saying, "Hey, we're going to have to invest in doing this and go out on the limb." It sounds like there were a cascade of events that happened. Do you see that happening across the U.S. now? Like, just in general, you think that it's here to stay? And
I'm sorry, you cut out on the question. I'm sorry.
No worries. And I was going to say, do you see more of this happening where you have health systems and payers wanting to invest in resources focused on interoperability, because it's at this point, you can't do population health without it?
I do. I think not only because they will see they want the efficiencies, but in a lot of cases there may not be a choice, right? It's being regulated as such. So again, this is where we got lucky, because we started making the investment a while back, right? But I do feel that organizations want to do this work. They are hamstrung by the inefficiencies between the communication between the payer and the provider on the DaVinci side. On the CARIN side, there's other regulations coming through where patients have the ability to access their health information at any time through Smart on Fire, right? So that's something that organizations are going to have to comply with. So yes, but I do think they want to. I from the talking with my peers and others, I never get the sense that they are more intimidated by just taking on the lift, but they really they're excited to do it. I have not seen or at least heard personally organizations that don't want to get involved, stand up this type of architecture to be able to do it.
Got it.
I want to invite anybody watching. It seems like we have a ton of people in the audience. Feel free, ask questions or make comments or anything like that in the last couple of minutes that we have. And it looks like in that time we got one. Okay, so it's not. Let me let it tell me the name of the person. Oh, okay, Mike. So what data sources are most valuable in these efforts? EMR, payer, or any others?
Oh, so thanks for that question. That's getting into our second use case around the bulk membership load. So it's really the claims, the EMR, and then the member roster. And the member roster, I have had more meetings about the last few months, because that is our next use case to work on in DaVinci, right? Where we're actually going to take instantaneously receive the roster information from the payer and be able to push back any errors or reconciliation instantaneously. So without that, understanding the attribution and who is your patient in a population health contract, really a lot of the work can't be done. So that is, that is a piece of this that is That is probably the most important piece. So that is the next project we're working on through FHIR.
And it's great that some of these questions illuminate some of the topics that you were planning on talking about, and some of the questions that we put together. Curious about gaps in care, that kind of the third use case that you were planning on discussing as well.
Right. So gaps in care is going to be our third one, as you mentioned. And this is really to iron out the disparities between the claims and the clinical information, as well as the incomplete information we have about, mammograms, colorectal screening, colorectal cancer screening, that is, and so forth. So this, you could see how this one directly applies to the patient is, something that we grapple with since my career started in population health. We have grappled with, right, how to get this care gap closure, and really ties into some of our CRM strategies as well. I think it's important to note with the gaps in care, it's going to be bi-directional as well. So not only are we going to be ingesting data from the payers, we're also going to be pushing back not only the gaps in care from the EMR or clinical side, but also when we see errors, when we've found errors through our auditing process. So this is going to be done instantaneously as well. So really the vision there is that it could happen right at the point of care during a doctor's visit if there is some sort of error that's happened. And CMS has already piloted that and has had it working where it is actually at the point of care. So again, our government is the most innovative here, which is very hopeful, I feel.
So it sounds like there's, in terms of speed to value, speed to analytics, the speed by which you're able to access data, that's increasing tremendously. And in a lot of cases, a lot of where people were comfortable with the status quo, it's just something that they hadn't thought about before, the ability to take that down from 45 days to instantaneous. So
right.
The question then, so there's a question that came in from Kathy Rhodes that's about, hey, what's the average amount of ROI that you've seen so far? So there's all kinds of capabilities that you're measuring, that you're creating, that I think might not have a tangible way to measure it, but just very obviously improves the patient experience and improves the experience of everybody who's interacting. But wondering, as far as like the overall ROI figures, is that something that's being discussed, and ultimately how and I guess what kind of returns are you guys seeing from that?
Right. So it's still early days yet. We're still just starting to see the benefit of that. But I'll tell you, we had a team of people, of FTEs, that just babysat and claimed files and waited for files from the payer. That team is now doing other things. So in terms of FTE hours for the ROI, we had a team of 5 people. So if you think about what that means for the organization, that they're no longer, that technology has now replaced some of this manual auditing that they have done, just sitting around waiting for files, calling to see why haven't you sent the files are wrong. That in itself is starting to prove out the measure we had, which was the FTE hour spend on doing this work, as well as how much a misattribution was costing us in write-offs for perhaps a member that acquired services that wasn't attributed to us. We would write that down as an organization because, they're seeking care. That is the business we're in. We are going to give them the care, but they attributed life to us. So
it's impressive. The real-time piece I picked up, and I didn't know that that the interoperability standards that are coming through the regulations on the gaps in care will be real time, that at the point of care. That I mean, it's hard to measure ROI there other than we're actually doing the right thing on behalf of the patient. I mean, that's groundbreaking.
Absolutely. I know myself as a patient, I have been a person that's been at the other end of an error, right, where my lab results just did not arrive, and I had to go through another round of testing and waiting, where was cost me and the payer, obviously, as well as time time spent that at the provider side that could have been seeing other patients. So you can imagine being able to chew that up right then would be a real patient satisfier.
Yeah,
so.
Absolutely.
Well, and this has been absolutely fantastic. And I just want to say that this work that we're discussing here, the benefits to the patient, the benefits to people that are interacting, basically your internal customers, it's blatant. But we've been in this operating environment for so long that a lot of people are kind of used to and accepting of what the status quo is. But now you guys are like taking some of the first or early efforts to be the torchbearer and lead the change and say, hey, patients, the expectations that you have about your health system, we can actually start to meet those. So kudos on that work. As we're winding down, I want to thank everybody who stayed on with us past the hour. It's crazy how we only had budgeted 30 minutes, but people still stuck on. So thank you for that. Any parting words or thoughts for the people out there that are thinking through these initiatives or thinking, how do I get this done in my organization, or where do I get started, or just how do I even start understanding this stuff?
Right. So, gosh, I don't know, eating the elephant one chunk at a time. Right, solicit that executive buy-in, engage a technology partner who will take the leap with you, and narrow in on those DaVinci use cases that are widely publicized. If you go out onto the HL7 website, you'll see them. Shop those around to find a physician champion. I didn't talk about that, but we did have an engaged physician champion in our departing CMIO. So shop those around and see which ones will get traction, and then build your ROI and selling it to the wider organization. I think that those are the steps we took. It is bearing fruit, as well as I will say we stepped in it a few times. There are things that we have failed at and we have learned from, and the organization has been patient with us. So, you're remembering that we really are doing this for the quadruple aim. That's why we go to work every day. When I was frustrated or failing at things, that was what motivated us to learn and start not over, but go a different direction. So,
well, kudos to Anne, to you and the entire team at MultiCare for really leading the charge here, and we're looking forward to seeing some of those business case results and continued progress. So thank you again for joining us this Friday.
Thanks for having me.
Absolutely, Anne. And
be well.
Thank you. And just for the audience, we're going to be doing a couple of live sessions next week. We're going to have a more marketing-oriented conversation with Gene Hitchcock, who works with tons of healthcare systems across the nation. That'll be on Wednesday. We're going to be doing a little bit early. And then we have Ray Morales and Chinli Kandi from Intermountain Healthcare to discuss their data-driven outreach within the kidney care department, which there are lessons in terms of next best actions and predictive analytics and prescriptive analytics. There are lessons in that can apply to numerous service lines. But we wanted to dig in deep on, hey, what does an AI-enabled use case look like? But again, thank you very much, and hope everyone has a great weekend.